rupture of silent rupture of AVM per embolization, different origin. One is why I named this silent, because it's not you don't have any change in the blood pressure, any change in the flow in the vessel, but finish and you are CT controlling angio suite and you are bleeding. The first example is the secondary to hyperpressure during injection onyx in nidus. This is one example, one period-occipital AVM. This is the embolization with onyx. And after the control, you are bleeding, asymptomatic. This is one point is you need to be careful with the pressure cook or another technique. Sometimes you need a stop because you rupture the small arteriolas. The second is most common is after rupture, after removal, the catheter, asymptomatic, no change in the blood pressure, asymptomatic. Means you need to check very well. This is AVM. After removal, you are only here in late phase, this image. If the patient have all the hematoma and the bleeding is in cavity. I selective study, and after some pedicle, I embolize with this part with glue, and this is the bleeding. Finally, and this is final. And this is another case. It's very interesting because it's have a rupture after 30 minutes. After 30 minutes, the final embolization in the same angio suite. This is the frontal AVM with a bigger cortical single vein, frontal vein. This is the cast of onyx, and only what is this? Is a stop flow in the vein, but don't worry, wait. This is the cast of onyx. You have the same. Final angio, 1234. The vein is patent, no change. Don't have change in the intranidal morphological chain of nidus, but 10 minutes later, the vein size change spontaneous. You are a stagnation of the contrast. 10 minutes later, more change, and the vein changed the direction. Hemodynamics vein, another new vein. You are controlled with this anastomosis, Sylvian anastomosis. At the beginning, don't exist, now yes. And the vein is still bad flow. The patient developed one subarachnoid hemorrhage, 38. 50 minutes later, bigger hematoma. And after surgery and after remove the hematoma, I removed the AVM. But the question is this point. when you see the stagnation of the contrast in one part of the vein, be careful, because you have the possibility the continuity is progressive thrombosis and bleeding. And this is the last case, AVM, thalamic AVM. I embolize with, this is the MR, AP view in the right carotid, left carotid, venous, pouch, thalamic and lenticular AVM. I decide to treat it. This is the vertebral. I decide to go with the arterial and venous approach at the same time. I start with the venous, but it's impossible because you are more high flow in the vein, and this is the onyx. You are the signal. This is the vein. I decide to continue with the, sorry, this is the onyx in the vein. I decide to continue to arterial. After 2 hours embolization, this is the control, the cast, control angio, still remnant AVM, less volume, less collateral circulation. The patient is still well, and 24 hours after develop hemianopsia, you are here in MR, some hypersenial, perinidal, but this hemianopsia is not during embolization because it's checked the patient is well. It's about progressive edema around the discussed onyx. This is the reason of you are be careful to put high quantity of the onyx in deep AVM. Okay, thank you. Any question, any comment? What do you think, Jack?
I missed the first case because
No.
I had an emergency,
Okay.
telephone emergency. But overall, if
The
I
case of
do
the vein.
understand and I captured some of your words, be careful when you see stagnation of the venous system. Be careful, okay, but why should you be careful? No. Let me answer.
Okay.
No, I answer. You should be careful because venous stagnation is leading to venous thrombosis. And what is the result of a venous thrombosis is hemorrhage. So when you see venous stagnation, the first thing that you have to do is to put the patient under anticoagulation. And this is the key. If you put the patient under anticoagulation, you avoid or you limit as much as possible this extensive thrombosis, and then you can get rid of this kind of complication. It's never 100%, but it limits a lot. Since we are putting the patient, I thought that everybody was almost doing that, putting the patient under anticoagulation after this.
This is bleed the patient, and you put in this moment anticoagulation.
No. You do the treatment. You see venous stagnation on the control angiogram.
Yes.
You go with anticoagulation.
Okay.
It's too late now.
It's too late.
It's too late. The patient has to be, anticoagulation is protective. It's not curative, it's protective.
But
when you see that, you might expect
anticoagulation is you have the possibility they still open the vein?
No. Yes. What's the treatment of venous thrombosis? It's anticoagulation.
Yeah, yes.
And that's the reason why you avoid having this complication. It is that simple.
Agree.
It is that simple.
I think the anticoagulation is more dangerous.
No.
What?
No. I accept your comment. You should accept mine. I have no I have no scientific proof to say that, but you know, when we started doing the treatment of aneurysm with coils, there was no studies, no randomization, nothing, and we were fighting with our neurosurgical colleague. And what has happened? According to time, the result we noticed were getting good, and finally, ISAT claimed that it's better to do it. So we just have to take care of our experience, and instead of just speaking and speaking, we have to try to see if it's a way to do. And if it's a way to do, we have to do a study. There is no way to exit from this trap. You know, a study of patients, a cohort of patients which is done endovascularly and anticoagulation, and another one which is done endovascularly and no anticoagulation. Okay. This is a way to go, because you have your feeling, I have my feeling.
Okay. Respect
it's
your
based
feeling.
on your experience, I respect it. It's based on my experience.
Okay. I respect, totally. My question is, CUR, drop the pressure in the vein, Jacques, anticoagulation. In my opinion, call neurosurgery, prevent, because if the patient bleeding, you going to your surgery room.
That's exactly my point, Luis. This is a left frontal polar lesion. Again, if I see that venous stagnation, that lesion is coming out. If I could not finish this endovascular, that's a craniotomy, that lesion comes out. And again, I don't know, Jacques, if IV heparin is going to prevent this. I think that's, you have a lot of experience with that. I have zero. But in our center, if that left front polar that I went for EmboCure, I couldn't finish, that is coming out. It makes for a long day, but I think I sleep better after that.
You mean you remove it?
Yeah, remove it.
Yes.
Yeah.
But many of those you cannot. This is different. This lesion is specifically very surgically accessible.
I totally agree with that. There is no question that you can remove when you see that you can go for surgery and take it. But if you don't want to do surgery, because there is a debate, you can manage this patient by waiting, putting anticoagulation, and then bringing the patient back for another session. This is a different strategy. But there is no question that you can remove it. And, you know, to be sure that we have better result seeing these pictures with surgery immediately done after embolization, it will be a crucial answer. Honestly, it would be a crucial answer. And I totally agree with that. I would never be reluctant to send the patient for surgical removal, seeing this instead of putting anticoagulation. If you can show me that the results are better, I agree.
Okay. Next speaker. ¿Quién es el siguiente?
I have another question. Which is, are you running after time? No. Because, you know, this kind of small meeting is probably good if we keep on discussing. Okay. So the question is, you and me, we are neuroradiologists. We do our business. And then we have this situation. And we decide to do surgery or to send the patient to surgery. We cannot do surgery. We send the patient to our neurosurgical colleague. How easy it is for you to convince the neurosurgeon to do it? This is a point.
No.
Because, you know, the patient is sleeping. No.
In my center,
let me ask the question. Let me ask the question. It's not easy. No? You put the patient on sleep. You do this. This is your last control angiogram. The patient is not awake. You call your surgeon and you ask him to remove it. What is he going to say? Fuck you. I am not going to take the risk of giving the complication to the patient.
Fuck me, no. The patient.
Yeah, this is a problem. If you are both neurosurgeon and doing endovascular, you can take your own decision. But if you beg, please, do surgery on this, the patient is going to bleed. So the guy said, I will take the responsibility and the complication.
Micro.
Before the embolization.
Micro.
Okay. But before taking any decision to treat the patient, we discuss with the patient and with the neurosurgeon as well.
Ahora no puedo.
What
Estoy
is
en un
going to
congreso.
happen if there is a complication or if the embolization is incomplete? And then we know that we have to take the risk as a team. This is the key point. One cannot do the embolization without having a good vascular neurosurgeon aside or without having the ability to do the surgery on his or her own. This is key. I mean, if you stumble upon a situation like this and then the neurosurgeon will say, fuck you, this is normal because we have not discussed before. You got to discuss beforehand with the neurosurgeon.
Helsinki, we will say, of course.
Okay. I have a very simple answer. We all do that because legally speaking, you have to do it. If you don't do this kind of meeting with a summary of the meeting, we are legally in danger. So it's done. Okay. This is following the law. But then you have reality. You do the treatment, the day you do the treatment, the neurosurgeon on call has done 2 AVM in his life. Is he going to jump on this one? He says, no, forget. You cannot say that all the surgeon and all the endovascular guy are at the same level of skill. This is the problem. You are in the middle of the night, you do an AVM treatment or you do an aneurysm, okay, and there is a big bleed and there is a big hematoma. He has not clipped an aneurysm for the last 10 years. What is he going to do? This is a big concern. Tomoaki, please stand up and raise and say something.
If I look at the final angiogram, that's a very dangerous situation. I definitely go to surgery. Yes. No. And also that's front tip. The surgery not so difficult. If we control the bleeding is difficult, just frontal lobectomy is done. It's okay. Not so difficult case for this AVM. I definitely agree to the Hanel.
But you don't have to beg to your neurosurgeon because you beg to your...
Yeah, I do by myself.
It's not fuck you, it's fuck me. But I like the way you put this, Jacques, but I'm going to go a little bit in a different direction. I'm going to go for aneurysm embolization EVD placement. It's not uncommon that we see non-neurosurgical interventionalists having an intraop rupture and the patient suffering because there's nobody to put an EVD. Again, the non-neurosurgeons, you guys, neurologists or neuroradiologists, you do the things that are way far more complicated than placement of an EVD. And when you talk about it in any country, to train a radiologist or neurologist to put an EVD is an act of Congress because it's all about turf. It's not about the patient. Every single person embolizing an aneurysm should know how to put an EVD with eye guide, eye start, or whatever. Anybody can put an EVD. So we need to break this paradigm because this hurts patients.
And it is simple for me because I know the way to do it. So. You know, in the angio suite, we have the kit which is ready for that. We call the neurosurgeon. The neurosurgeon usually, they are good friends to come, but if they cannot come because of something, we do it ourselves.
Perfect.
Yeah, to put the drainage. But who is able, as a radiologist here, to put a shunt?
But not to remove the idea.
No, but putting the shunt.
Okay.
For life-saving.
This is life-saving. Again, AVM resection is a different beast. I'm talking about a drain placement.
I totally agree. And if you look at the recommendation of the World Federation, it's not written. If you do endovascular treatment, you have to have the skill to put a DV. No.
Yeah, but Louisa, but by the time somebody bleeds, by the time the neurosurgeon, again, it depends at different realities. But again, I've seen patients transfer to us 2 hours later because this neurologist was coiling an aneurysm, and I have nothing against that. But again, it's a problem that you're doing that, and this is happening in the United States more and more and more often, that you have these silos of very good endovascular, but no backup neurosurgically. So that, as Jacques said, the neurosurgeon is doing spine surgery. By the time he's finished that spine procedure, 2 hours later, the cat's out of the bag. So.
neurosurgery.
But if it is a life-saving,
If
needs to be done, it's like CPR. It's not like, oh, I'm gonna wait for an expert to arrive. No, it's right now. Yeah. And it's silly that we do flow diverter for posterior circulation, complex aneurysm. If you cannot do a single burr hole.
Yeah. No, but you know, there are a lot of centers that have been done in endovascular without neurosurgeon, and that we should not agree with that, because they are complementary techniques that we should work together in the same hospital. If I need a DVA, I just call the neurosurgery. We have always 24-hour neurosurgery. Of course, we don't have the specialist to take out the AVM in an emergency, but we can call the vascular neurosurgery if we really need, but we always have a neurosurgeon. So I think this, not dangerous, but complicated techniques that always can go wrong, badly. If it is an easy case, it always can go in a bad way. We should always have the backup, and there are techniques that we should not work in a hospital without having the other one. As neurosurgery, they want to have neuroradiologists.
You are living in a dream.
Okay, thank you.
You call the neurosurgeon, he's in your hospital, he doesn't come after 5 minutes. Oh, forget. So what are they doing? What are they doing? They're having coffee, waiting for you? Okay. So honestly, no. Yes, but you know, how much time do you need for him to come and do it? The second point is, what do you do with your patient? He is in the angio suite and you want a DVD. You transfer to the OR. It takes 35 minutes. It takes 45 minutes. It takes an hour. It's crazy. You have to put the shunt in the angio suite. This is the way to go. So transport, call the escort to transport, half an hour. Then they go there. Then install the patient, half an hour more, 1 hour later, the patient is dead. Forget, the shunt has to be done in the angio suite. That's it. Yeah. In the angio suite. But how many neurosurgeons accept to do the shunt in the angio suite? Yes, but how many in the world forget about your own home? Yeah, this is the problem. We have to look at what's happening in the world. Call the neurosurgeon. You know, we had recently a very difficult spinal cord AVM. The only way to do this spinal cord AVM was to attack it from the venous system. You know, attacking the venous system for the spinal cord, it's not easy. So we decided to ask the surgeon to open it. It took 2 weeks to convince them to do it in the angio suite, which is normal. They don't know the environment. They don't why it's. I say, open the box and that's it. And then we care about it. Finally, they did it. They opened the box in the angio suite. We did it. The patient is cured. And sometimes, and it's not uncommon, they don't want to do the shunt in the angio suite. They want to bring the patient, what you said.
This is your local problem. The hospital is not. Problem.
It's a problem. No.
Wait.
No, it's not a problem in our hospital because I accept it. But for example, for Visa, it's a
Just a minute.
to bring the patient to the end.
I stayed in November with Hanel in Jacksonville and with Jabur in Philadelphia. Both is neurosurgeon. Both in the same center. You start with endovascular, you have a problem, you continue to open brain. No discussion. You are every. You don't have problems. See the patient bleeding or not bleeding or no. This is important. The problem is the neuroradiologist. I am neuroradiologist. You. I stop because I don't. No. It's not possible for me to open the. Going to the surgery room, continue to treat the patient. I please neurosurgery to come. No, this is true. This is the problem. But this is my problem in Madrid, your problem probably in Bisset, but not the problem in Philadelphia or in Jacksonville or in Japan.
But Luis, but the point is, if a patient, and when I was in Buffalo, everything was done away, everything done away. So you see when you rupture an aneurysm, sometimes the patient does not care. Mr. Jones, everything okay? Yeah, I have a little bit of a headache, but sometimes you bleed an aneurysm, and the patient just like, boom, rocket down. This patient, you don't have 30 minutes, you don't have 1 hour. The ICP is an immediate flow arrest. Exactly. And we see this on the angiogram when we do the injection. So what I was trying to simplify, not to create too much discussion, is I think it's silly as a global community representative here. We have opinion makers here. We can go to our societies, and it's silly that we don't train. Neurosurgeons don't want that. I don't care what they want. I care about that patient that is bleeding on the radiologist, neurologist table. This patient may not have 30 minutes, 1 hour to be transferred for the guy to finish his spine, to finish his lunch, or to do whatever. EVD preventive? Oh, yeah. Low threshold. Low threshold.
Most of the cases we're doing an acute rupture aneurysm. In the end, you speak first in EVD. If it's a high risk patient, you do an open EVD because you release too much CSF rupture. So we just do EVD. And so we get a couple of cases where we get intraoperative rupture and open EVD, so directly the blood from the aneurysm into the segment of the EVD. And when it stopped, it was fine. So most of the cases we will put the EVD in the angio suite before.
But what Jack is saying is different. You may do it this way, that way, the other way, but what he's saying is that we need to, I'm sorry. What he's saying is that we need to create a new creature, which is called INR, who has to have a proper training, not only doing a coiling or stent-assisted coiling or flow diverter, but also to do the simple life-saving neurosurgical procedures. This is it. There is no discussion on that. Do we? No.
A radiologist does percutaneous brain and every other place in the body. Why can you not do percutaneous brain to the brain?
Yeah, Emma.
There was no CD. We were doing this intraventricular injection of Viodol.
Yeah.
We were doing it ourselves.
Yeah.
It's nothing.
That's not it.
Yeah, we have, I'm a neurologist and we have a really good relationship with the neurosurgeons at the University of Iowa, but sometimes the neurosurgeon is, doing a spine case or something and we have a complication. And I think, what said Ricardo is more like of a political issue with each department doing each stuff, but for sake of the patient and since we have governing people that are in control of SNIS and SBIN and the World Federation, part of the requirement should be that every people that are doing angiograms and doing this type of procedures, they should be trained in doing an EVD. I think that's excellent alternative.